Mr. Chairman and member, Donna Brownsy.
Thank you. Thank you.
You are so welcome, sir. Donna Brownsy on behalf of COMP. I just want to distinguish who I represent just for a teensy bit because it's important to understand in terms of the context of the conversation and my comments in response to the number of issues that are in this item. I represent the narcotic treatment program clinics, and so they are different than most of the other outpatient drug-free and other modalities in that we are licensed by both the feds, the DEA, and the state, as well as we are required to be licensed as a medical clinic by JCO. So we are highly regulated for good reason because we treat the opiate-addicted population. We have now, as many of you know, a serious bump up in what's a public epidemic of prescription drug abuse, which is now producing 70% of the people who come into our clinics, as opposed to in the old days, it was heroin use. Now they start with pills and then move to heroin because it's cheaper. The reason that I'm saying this is because we are all constantly audited by the counties, and it's because we give people medicine. We are what is known as a medicine-assisted treatment modality, and the reason is because of the specific and situation of opioid addicts. So first, we want to say that COMP strongly supports all the efforts on program integrity. We, in fact, met with the department soon after the reports came out, recommended things that could be done, and we do believe that most of the things that can be done could be done by changing state law and state reg and state oversight. The fraud, et cetera, was not new. There had been complaints for many years, both by good providers to the counties and the state, but for whatever reasons, those things were not pursued. And I'm not trying to point fingers or lay blame because this tarnishes the whole drug treatment community. So what we also are very supportive of the expansion of benefits. We think it is so critical to have a continuum of care, but here's where we differ, and we are participating as part of the WAG, as part of the Waiver Advisory Group. We want to just state for the record that we have found the director and the assistant director to be accessible whenever we have requested. We have had numerous conversations. We're respectfully disagreeing for the need for the waiver. We believe that the waiver will not produce increased access, but will in fact produce decreased access. And let me explain why. The reason is that we have historic documentation that referrals to narcotic treatment programs have a long history of being underutilized by the counties to these programs. So the department itself documented in study after study that Prop 36 through the state courts that there was an incredibly low referral from the courts for opiate addicts to narcotic treatment programs. We also know that in AB 109, in the LA area, one of our clinic owners has 3 clinics, outstanding clinics. He has received 3 patients. Most of our clinics have received no referrals under AB 109. If you don't get an opiate addict into treatment at an NTP, they go back to using, which means that inevitably they're going back to jail. So our point is that we know that in these particular kinds of situations that we don't have a good track record with respect to access to these particular services. As I mentioned earlier today, we are experiencing counties trying to limit enrollment by restricting the number of slots when providers ask for increases, because we're seeing increases in our patient population for 2 reasons. 1, because of the ACA and the expansion, and 2, because of the public health epidemic that I referred to. But we can't treat these people if they come to us, they come to our clinic. Why? Because they don't want to get sick anymore. So they come to these clinics, they ask for treatment. If we've made a request to the county to increase our slots, we have to say to this patient, I'm sorry, we can't help you. Even though it's an entitlement, even though we should be able to treat them immediately, they go away. They don't come back next week or 2 weeks or a month later when we think we may get our approval from the county, because they go back to using. So they may cycle back to us in a year or two, but especially for the young people, because that is the fastest growing cohort. So what we're saying is that we also believe that a waiver of federal law in narrow circumstances, IMD exclusion, we get that, and there may be some other technical issues. But essentially, our understanding of how this waiver is going to work is the counties can opt in, and they're going to have an expanded level of programs and service that they'll be eligible to, but the counties that do not opt in will be working under the old system. So instead of creating a continuity of care throughout the state, we'll have two different systems of options in the state. And we really think that we should focus our efforts on improving the expansion of these benefits, and congratulations on the SPA amendment. We're very excited about that. But also, we think that we should be working and focusing our time on how we're going to accommodate all these additional patients, how are we going to ensure the continued involvement of the counties under realignment. Thank you, Mr. Chairman. I really appreciate the opportunity to share this information.
Thank you. And may the directors, I'd like to keep going with the public comment, but would like to circle back after the public comment to maybe address that concern of a patchwork, the concerns raised by Ms. Brownsley. Thank you.
Hi, Steve Mulhart with Aegis Treatment Centers. We operate 24 of these narcotic treatment programs throughout the state, 14 counties, including one in Atascadero in your district. I will be very brief because I think Donna was very eloquent in terms of our arguments. Since we deal with so many counties, though, we are at the center of a lot of the discrimination that goes on in terms of requests for slot increases, requests for budget increases being denied, capped, controlled. And that's in the current environment where the state is the single state agency, the responsible party, can overrule the county. We're very concerned with the waiver allowing for selective contracting, basically taking away the patient choice element of the Medicare system so that the county can manage an entitlement, manage a mandate. And we're not comfortable with that. We are participating in the user group, the stakeholder group, and I'm trying to learn as much as I can about the process and appreciate that there are some things that maybe should be done that way. I think there are a lot of fixes that we can do, and we've made recommendations on raising the bar and fixing the system without doing a waiver, but doing it internally with regulation and legislation. Thank you very much.
Thank you. And your participation in the stakeholder group, I know, is appreciated.
Thank you. Rusty Seelix, California Council of Community Mental Health Agencies. Our agencies do not generally participate in the drug Medi-Cal program, but would like to. They represent that expanded access that you could see. I don't think I need to explain the fact of the prevalence of co-occurring disorders, estimated that half the people who have a mental illness or alcohol and drug also have the other condition. The potential for integrated care and for bringing the programs together, the alignment of county alcohol and drug with county mental health, where our agencies who have county mental health contracts could have built into that contract under the same type of rate structure contracts for alcohol and drug is something we see as very promising, and we see that's impossible under the current structure, but would become more possible under the proposed waiver. So in our view, we see the waiver as leading to expanded access for the type of services and for the populations that we see. Thank you.
Thank you.
Kelly Brooks on behalf of the California State Association of Counties. We are in support of the proposed 1115 demonstration waiver. as the Medi-Cal program is moving more and more toward a managed care environment, and to the extent that counties are going to be responsible, today responsible for managing the drug Medi-Cal program, we think the discussion around selective provider contracting is an important one to be having in the context of the waiver. And I think generally, counties' incentives toward offering care and offering a continuum of services have really shifted post-2011 realignment, as counties are responsible for a larger offender population and really looking at how they provide services across different systems. And I think there's a lot of opportunity within the waiver to foster the kind of cross-collaboration between social services, between public safety, between our hospital and our health systems that hopefully result in the kinds of outcomes that we would all like to see through the waiver process. I think this is an opportunity to build our substance use disorder treatment system and test and evaluate at the same time. So hopefully we have a few different models that end up being standards of practice that we can take statewide after the demonstration period is over. Thank you.
Great, thank you.
Kristen Barlow, California Mental Health Directors Association, and similar to CSAC, we also support the 1115 demonstration waiver being pursued, and we do believe that given that it's a 5-year waiver, as those 1115 waivers work, it will give us a good opportunity to demonstrate and, as Ms. Brooks was just saying, test out the system that we're trying to build to be more robust and be inclusive of the new benefits that were added by the legislature last year. We support the state's efforts to give counties and the state an opportunity to do this effectively and efficiently. And secondly, wanted to mention that CMHDA is now in negotiations on a contract with DHCS to improve oversight for the program and to clarify the state and county roles for assuring high-quality services are accessible at the local level. Thank you.
Thank you.
Good afternoon, Chairman. Sherry Kreckenberg, California Hospital Association. We, too, are very supportive of the efforts that the Department of Healthcare Services is undertaking. We have a few concerns about where hospitals play into the picture. We're a weird entity or complex. People think that when they just use the word hospital or general acute care hospital, that they have the capacity to do everything, and they don't. We have chemical dependency hospitals that specialize in this area, and they're not included currently. So really need to spend some time helping educate people that need to be educated about hospital world. So thank you.
Great, thank you very much. Any comment on any of the testimony, but I'm particularly interested in the concerns raised about the waiver?
So I'll address those. I mean, you heard a lot of the points from other individuals who were in support of it. But again, fundamentally, we see the waiver as a way to actually improve access to make sure that that counties, to the extent that they participate, they're going to have all the modalities and required access to those modalities, and we'll be monitoring that. CMS will make those requirements. In terms of the point about two different systems, so let's go back to a couple things, and Rusty's given me the history too on the mental health side. Mental health started as a fee-for-service and was built out into a county mental health system, a lot to do with both ways of ensuring improving access as program integrity and creating a true organized delivery system. Our medical managed care, we have, now I am pleased to say that we have managed care in 58 counties. A couple of years ago, that wasn't the case. We had a fee-for-service and we had a managed care system side by side in different counties. We have the vision of all 58 counties moving under this waiver and having an organized delivery system. Counties will start in different places and will move there and move into the organized delivery system over time. And there will be lessons learned, as Kelly mentioned, that we can use as we expand it statewide, just as we've done in our medical managed care system, as well as in county mental health. But fundamentally, this is consumer protections and making sure that there's access in the system, and we'll guarantee that. I know that my federal colleagues will make sure that is there, and I know you all will make sure that we will continue to monitor and provide, make sure that consumer protections there access. And this is about a better organized delivery system and continuum of care, and not impacting access, but improving access.
Thank you. So we're going to move forward, but I think I'm encouraged by the commitment of all parties to the stakeholder process, and we'll be curious to see what some of the conclusions and recommendations are that come from that. And also, I think just broad overview, the direction towards better integration of mental health, drug abuse, alcohol abuse with our healthcare system, moving from body part medicine to integrated people care and patient care. It's definitely the right direction to go, and we appreciate the efforts of the department to make this successful. We're going to move forward. We're going to keep that item open, and we're going to move now to item 8, recertification of drug Medi-Cal providers.
Okay, and I'll be brief on this. We've touched a little bit on this as our efforts. One of our efforts is to recertify all our providers, and to do that, it's taking additional resources, so we're requesting 21 limited-term positions to do that work. And you asked about some of our efforts to assist providers, and we've done a lot of work on that. From webinars, we did actually a whole video training that's online to assist with the package. It is a very complicated recertification. We got a lot of feedback from providers about the complexity of it based on rules that go back to our previous Department of Alcohol and Drug, and help work through that. And in terms of the question about access through the recertification, if anyone's losing their recertification, at this point we have not taken away. For those who actually have submitted applications, they're moving through the recertification process. We did have some providers who never submitted the recertification. We did disenroll those who never submitted a recertification package. Now, those can, at any point, reapply and go through the whole process, but we did not. We feel strongly that we need to disenroll if they don't apply, because we don't know what's going on with that site.
If I could just interrupt there. So
yeah.
In the charts where you have sites decertified, those numbers can include sites that did not
exactly
affirmatively apply.
Yeah. Those are those who did not return anything. And then in terms of recertification, how it really couples with program integrity is it gives our ability to continue to assess. We look and we check against all different databases to make sure that there's no issues going on in terms of any inappropriate actions. We also get up-to-date information on change of ownership, other information. So it gives us the ability to reassess the composition of the provider and make sure that there are no problems going on. So it's a very important part of the process, and it is also part of bringing it into our department. We're able to take lessons learned of what we've done on the medical side and incorporate it into what's going on in substance use side.
And if I could just ask one of our questions. So the chart shows sites decertified, and then it also shows applications accepted, presumably applications for recertification. Do you have data on how many have actually been recertified?
I will have to get back to you. I will say it's very few. It's I think we just had one recently that was recertified, but most are still in the process. And we can keep you up to date on that.
And just kind of a ballpark figure of timeline on recertification process? Is there a?
I'll need to get back to.
6 months, a year.
We want to do it as quickly as possible, but it's balancing it with the complexity of we're giving providers the time to we send back if they're missing information to work through the process, and so it's a balance. And we're working first on high-risk areas, and we'll go to the others.
Thank you. And I do see we have some target dates in the charts on page 38. So those continue to be kind of...
There are targets, and we will, and I just don't want to given...
Estimate, right?
Yeah.
I think what we would appreciate is just ongoing progress, keeping pace with these targets, falling behind.
We can definitely do that.
That would be great.
Thank you.
And perhaps you touched on this, but what's the department doing to help providers navigate the recertification?
So this has been our ongoing, we've done a lot of webinars. We got a lot of feedback from providers about concerns with the process and how complicated it was, and that they were all getting told that they were not completing it. So what we then did is had our staff create a video that goes step by step through the whole process. So we've done that. We brought in providers to help develop that video. So we want to keep, again, this gets back to, we want to get good providers to stay in the program. We're actively trying to bring on more. This isn't about throwing providers off that don't meet it. It's about rooting out the bad providers in the system. So we're navigating that with some, an old provider application process that goes back several years. In the future, we'll work on redesigning the process so it's more user-friendly.
And it does sound that part of this recertification process, it's not just to expand availability, but to make sure there's integrity in the program.
Absolutely.
Great, thank you. LAO, any comments on this? Department of Finance, any public comment on this one? We do have a recommendation to approve, but we're going to just hold that pending reestablishing a voting majority. Let's move to item 9, substance use disorder program integrity, counselor and facility complaints.
So we are requesting some additional resources to help with investigating counselor and facility complaints. This is funded from our residential and outpatient program licensing fund, of which we call ROLF, but is contingent on legislative approval of the fee increase for licensed and certified facilities. We have about over 500 complaints that are backlogged, and so we are requesting the additional resources in order to meet the state mandate of investigating complaints and to effectively regulate alcohol and other drug treatment facilities. You had asked about the state laws. There is a specific state law for drug abuse recovery treatment facilities, and that's California Code Regulation Title IX, Chapter 5. And the programs are, if we get a report that a program is operating without a license, we issue a cease and desist letter. If we have not heard anything, they have 15 days notifying us, and then if we don't hear anything back from them, then we are able to levy some civil penalties of $200 a day. California Code of Regulations, Title IX, Chapter 8 are specific to the counselors, and then there's a process there that if we have received a complaint against a certified counselor, we have 90 days to investigate, and then they have rights to appeal, and then we have right to respond, and all of that keeps going on for 15 days until it is heard by the hearing officer. The request is then forwarded to the Office of Legal Services, and they can schedule an administrative hearing for that.
Our notes indicate that there's a backlog of 500 open complaints going back to 2010-11.
Yes.
What's the plan to catch up with those?
These additional resources
Will help
tremendously.
Address this.
Yes.
And what's the main source of complaints? Is it from consumers, family members? Where do the...
A wide variety. Hopefully you've gotten the chart. If not, we can send that to you that breaks it out as to whether they're counselor complaints or facility complaints.
We will look forward to reviewing that. It was not received in time to include in our agenda packets.
I apologize for that.
Good. So we do, LAO, any comment on this item?
We recognize the need for the requested positions to address the backlog. So when we project out the workload for the next several years, our projections indicated that there would still be a backlog when the positions expire. So we're recommending that the department be asked to report back next year on the status of the backlog.
Thank you. Department of Finance, any public comment on this item? We do have a hold open recommendation on this, and we'll look forward to seeing. I'm just kind of curious to see both how the backlog is being addressed, but kind of the group grouping of nature of complaints or source of complaints. And we'll move to our, I think, final item for the day's agenda, item 10, continuance of driving under the influence program evaluation.
So this is a request for $96,000 from the DUI Licensing Trust Fund. We would like to continue the evaluation of our DUI programs. And just a reminder, DUI serves 150,000 people every year. And so we did an initial study, which led us to want to study a little bit more. We want to be able to look at best practices, to have benchmarks and performance measures, and to be able to look at why folks are reoffending and why do we have repeats. The DUI study that I mentioned earlier was generalized in nature, but it laid a groundwork for pinpointing the direction we really want to go to. So we're looking to expand and to be able to develop some performance outcome measures, to be able to collect some data at the provider level and really identify overall contributing factors in the reduction of repeat offenders.
Thank you very much. LAO, any comment on this item? Department of Finance, any public comment on this item? Seeing none, our recommendation is to hold this, or this was an informational, hold open. So we want to thank you for your time this morning, this afternoon, and again, applaud the efforts. We look forward to our ongoing collaboration, and thank you for your service. We appreciate it.
Thank you.
So members or remaining folks who are here, we had a couple of hold open items, and we had one item with a recommendation to approve, lacking our quorum to hold a vote. I think we're going to return to those when we are next in session, and we'll lead off in our next Subcommittee 3 hearing to record votes on those final 3 items. And with that, we'll stand in adjournment. Thank you all, and have a good weekend.